Alrighty, so I get the last talk of the day. My name is Steve Rocereto. Been with Rebound for 10 years also. We're going to be talking about some return to play considerations. Instead of going through ACL rehab, I thought it would be better for us to go through some return to play decision-making processes, since that's kind of what we have to do as athletic trainers. As the patient or your athlete gets cleared, what are you doing to ensure that they have a safe return to play? What's currently out there? No disclosures, sorry. And so that's why we want to talk about this. It's kind of, I think as trainers, we're put in positions by coaches, parents, other doctors, the pressure for kids. Everybody's got a scholarship type of idea, and it does. I work out at a high school also, and I get those questions put to me quite a bit also. Summary of the talk, we'll talk about some re-injury rates. We'll look through an ACL typical protocol, why the injury rates are important that reflect that time frame of return. We'll look at some current literature, and then I'll just kind of go through piecing together a return to play process that I go through. It's not that it's right or wrong. I think taking through research that's out there, we're going to kind of make a plan of attack to make sure we make the best decision for our young athletes. Starting with just some quick research, just quick bullet points. There's a lot more through these, but just get an idea of, first of all, we know about females having a higher risk. There's also more injury risk in this study with the contralateral knee, the other knee, and other injury rates. If you were under 18, having a higher risk of 17% versus being older. So it starts to build our picture of our group, the group I deal with now in the high school, of why they are at a higher risk. Another study, under the age of 20, females 3 times higher incidence of the contralateral, and that's from a study where they had an average return to play at 7 months. Another one, American Journal of Sports Medicine, the injury rate within 24 months for a female was 5 times greater, so now they're extending out, they're doing more studies beyond 2-year follow-ups, they're going to more 5-year follow-ups and finding out that there's still a higher risk within those first 2 years. Athletes under 25 have a 1 in 4 chance of re-injury if they return back to their sport. This was a male study, not so much females, but again, but 1 in 4 through that, and with early return to play being one of the culprits. So what's out there for return to play? There was a consensus statement in 2016. So they came up with some bullet points here. Return to sport, the RTS, they found that there's lack of evidence. Return to play decisions should be accumulated with a bunch of tests, not just one factor deciding whether or not a person is ready to return to play after ACL. The workload that they're going to be going back to, depending on the sport and how often they'll be playing, should be taken into, and then the psychological factors, which we'll be talking about also. Study by Dr. Noyes took 10 years of publications dealing with return to play, return to sport. 40% of those had no criteria based. 32 was time-based only, which we'll see isn't a bad thing. And then 13% took objective criteria, but there was no consensus for any kind of release to sports. Another study in 2017 started putting together test batteries. So in other words, taking more than one factor. They used isokinetic testing, some hop testing, landing. All of them tested at 6.5 months post-op, and all of them failed except for 2 on their criteria for return to sport. In 2016, they took 6 tests, 3 hops, isokinetic, and a running test. The athletes that didn't meet that had a 4 times greater risk of sustaining ACL graft as they followed them out. as they return to play. Rush Orthopedics in Chicago developed a functional sports assessment. So they took those battery tests, they took that information, and they came up with 9 assessments, but their idea wasn't to use it to clear people per se. They did their functional testing at 5 to 6 months and used it to try to identify where that athlete might need more and more work and help guide the therapists and their athletic trainers to concentrate more to help them return to sport. So they're using their return to play or return to sport factors differently. There's some time-based data out there. This is a big result here that they took return to sport play, and the average return was 8 months. I threw that other part in there because anybody who returned before 5 months suffered a re-injury, which we don't really see people returning back before 5 months. Maybe the ones we don't hear about or who don't come to rehab, right? For every month, though, that the return to sport was delayed, they found a 51% decrease in re-injury rate, up to 9 months. So time frame wise, they're starting to find that we know there's biological healing of the ACL graft, and it continues up through that first year, but after up to 9 months, there was a significant amount of chance for re-injury. Hewitt and them, even though it's not per se a study, they just did a review of literature, and they're finding that all their review literature was done past 5 years on follow-ups, and they're finding that the greatest risk was in those first 2 years, so 15 times higher in the first year, 6 times higher in the second year. So we kind of see we're building up our return to play protocol. We're seeing what group is more at risk, right? We know our young females, we know our young athletes, and those going back to sport in high school or young college athletes. So we're posing the question, what's your return to play process? I'm going to go through kind of what I do. I have 2 different scenarios, well, 3 really. I have a high school process on coaches calling me, so-and-so's had an ACL. I don't know who they are. What am I going to do to help guide them through back safely? I have physicians. Dr. Roberts loves to bring somebody over to me in the clinic and say, this is so-and-so, he's 6, 7, 8 months out, he's back visiting because I did his surgery, he lives somewhere else. Can you do some tests with him? So now I got to go through that. And then I have my own patient load that I carry through, and I'm lucky enough to see them through 5, 6 months of rehab, and then what am I doing with them to ensure that they're returning back to sports safely? Are we following clinical decisions? Are we following a algorithm? Are we moving through step? Are we checking boxes? Just get an idea of, you should be formulating some idea of what you want to do to make sure that you know objectively what's going to make your decision on letting somebody return to play from an ACL. So I gather as much information as I can. I call it my little puzzle pieces. I'm gathering as much as I can. Am I building an athletic picture, or do I have parts of it missing? Okay, so that's kind of what I try to do. I use pretty much a systematic system, whether it's check off or anything, I try to flow through. So not knowing a patient, if I'm in the high school and someone transfers, we get high school kids transferring because of coaches and things like that. And so Johnny had an ACL 9 months ago. What am I going to do? Well, I'm going to go through these things with them to make sure. So history is going to be really important if I don't know the athlete. If there's someone in my clinic, then I'm going to start on my neuro testing protocol, which we'll go through here. I'm going to test their kinesiophobia, see how they deal with their own pain and fear of movement. Flexibility, range of motion, that's pretty standard. Strength, that's pretty standard. They should be at a certain point if we're seeing them past 6 months. Then we're going to test through neuromuscular control. Performance training and sport-specific drills, that's my favorite part as a trainer. I love that part. That's field rehab. That's getting them out. They've been gone through all their neurological testing, and now we're out on the field. History stuff, We got to know when, where. As Dr. Fraser was saying, the allograft, if we have a young kid under 18 with an allograft, you might as well stop here and just, they're done. I would advise them not to play. Was there any other knee trauma with it? Did they have physical therapy? How long? So we're getting all this information, especially you at the high school. Sometimes they'll come from other PT clinics and they'll have their doctor's note and they'll say, hey, we're good to go, we're cleared. How do you know? Got to get some information. Hopefully you can call the physician and get some information about the surgical report. Some of the landmark questions I'll ask people: jogging, typically 3 to 4 months in ACL rehab. Have you done some neuromuscular training program? We start ours at about 5 months. Performance training, agility training, usually we're starting that after our neuro program or our neuromuscular training program, up to 7 months depending. Return to practice, 7 to 9 months. Subbar earlier, Dr. Fraser said 6 months for some, and some are phenomenal. Most of the time we're trying to delay though, if they're under that 20 age, if they're in high school, then we're shooting for a 9-month return to sport. Kinesiophobia, Tampa scale 11, goes through an assessment of fear of re-injury. It's a great little 11-question thing to give to the kids. I'll give it out at 6 months after they've gone through some rehab, after they've gone through their neuromuscular training. It has been shown to help those kids who haven't returned to sport in 1 year, so identify those. So it's a list of 11 questions. The scoring is 11 to 44, so each question is 1 through 4. They would try to answer these questions here. They strongly disagree to strongly agree. These are the actual questions. You can find it online really easy. And as you go through, you can tell that when you get your answer, usually the data's out there. There's a lot of good articles correlating to ACL rehab. And usually the cutoff is around 22 is what I've been seeing as a score, as far as a midline of being more fearful or not. And those are the other questions that would come up with it. So it's good to do. There's some articles out there, like I said, comparing those, some recent, some a little older, but you can find them out there. Flexibility and strength, won't spend a long time on this because they should already be there. The big one for me is one we know: core, proximal stability, FMS screens, other flexibility tests. But the ankle dorsiflexion, that's been a lot lately. Our own Journal of Athletic Training looked at and associated greater dorsiflexion, less risk of ACL injuries. Another study done: females with less ankle dorsiflexion exhibited greater peak knee valgus angle. So it's good to look at. Okay, there's a lot more with the dorsiflexion, so keep that in mind. So we do a little weight-bearing tests, lunge tests in the clinic all the time. We're measuring that distance from the toe to the wall on right and left, and seeing where they touch, just looking for symmetrical limb symmetry. And so that's kind of what we start building our picture of the athlete now. So now we might do a Y balance. I want less than 2 centimeter difference. You can use anything. We use a little mat slide. I'm going to look at anterior. I'm going to look at posterior medial. I'm going to look at posterior lateral as they go. Again, comparing right and left and starting to build our picture. Then we're going to get into some neuromuscular control tests. I'm looking for 90% or better to get through this phase. I'm looking at dynamic stability, and I'm going to use my video. It's a 5S. My kids love it because it's really old and they think it's an antique, but it does work really well. We're going to start with some step-down tests. We'll get some scoring done, or you can use single leg squat tests, whichever you want to call it. Usually we're trying to get them to 60 degrees of knee flexion as they go. Those are errors that we would score them on. And again, we're just looking at quality of motion, quality of movement. Is it good? Is it medium? Are they really poor? Trying to get one test score piecing it together. This is Emma. She is the #1 rated 7th grade basketball player in Vancouver because she's my niece. So she volunteered. She's not injured, but we see a lot going on for a 7th grader, don't we? This is Lauren, one of our co-workers. So you'll see a difference in strength to a certain point. So it's good to just kind of film a bunch of people if you're working with a team, working with a volleyball team. Usually we'll do this with the whole team and just kind of get more and more you look at, the better. This is Crew. He had an ACL reconstruction, and I'll let you guys decide which leg it is. Yeah.
Yeah, it's gonna clear.
He is only 3 months out, but he was good for video. Yep, and look at yourself, Crew. Yeah, that guy's better. We'll go through some single leg hop tests. So now we're just getting more and more limb symmetry stuff. I need this stuff be 90% and above. Whoops. We'll do the triple hop. Sorry, I skipped the one, not that it's a big deal. Single leg hop. We'll look at crossover hop. This one's a time dependent one, but I don't really worry about time. I mean, it's going to be pretty obvious with how they do it if there's an issue, because you're just comparing right and left, again, just looking at functional movement. So they'll go through a one-legged as fast as they can in control. Box drop, we'll just take a look at mechanics. So you can slow it down, you can stop it, you can do a lot of stuff with it. She shifts over. Oh boy. That's fast. Mm-hmm. Yeah, makes me cringe. Then you can do it, you can slow it down. Ah. Funny, we see a lot more on the takeoff these, don't we? Tuck jump assessment, we'll use the tuck jump looking, sometimes I'll do it at 5 months, at 6 months, and then later if they need it. So I'll use it as an assessment tool also, besides just looking for errors. Those are the errors you're looking for. The first 6 seem to be a little bit more controllable than the last 4. So it's a very difficult jump. If any of you have done your plyos and gone through, we use Cincinnati Sports Medicine as our neuro group. Tuck jump's one of the hardest ones to do. And then from the side, looking at knees parallel, heels coming up, landing in the same spot. Not too bad from the side. Get a little different view. Hair mop. Obviously stronger, but still doesn't quite finish her flexion. Kind of hits stop and gets into that extension right away, which we don't want to see. One of our ACL reconstructions, he is about 6 months out, and he's going to take his sweet time doing it. So we'll start both at the same time. But he actually looks pretty good. So for a big guy, he gets up there pretty good. Yeah. he looks pretty good too, so not too bad. Then we'll take the complete opposite. So Ryan here is awesome. Here's your 14-and-a-half-year-old kid who just thought, oh yeah, it's just like a little bruise. My ACL surgery is nothing. And that's the way his whole rehab has gone. And he is just a jackrabbit. And when we went through his plyos, it's like his technique was good, but it was always at 1,000,000 miles an hour. So I'm not sure about how much strength development we got out of him. He's repeating his neuro program right now. So take off. Yeah, no pause between. He just goes and goes and goes, and he's, yeah, pretty amazing. But looking to get to baseball in the spring, so and this was back in October, so again, just things to look at. This is Ryan, so this is a great case because his knee actually dislocated on me out on the field, and had 3 ligament repair, had drop foot, that's why he's wearing the AFO for now. He's about 1.5 years out, and he's now getting feeling in his toes and his feet. He can dorsiflex, he can evert. It's just waiting on the big toe to come back. And we were filming, and he just wanted to be filmed because he's just like, I'm an athlete, and that's what I want to do. He's actually doing really great. He's starting to run now without his AFO, and he doesn't look too bad. Get up there, Ryan. Get one side view in, and then we'll go. So what if I have someone fail at this point? Well, then we're probably going to, either if it was me, we're going to repeat their neuromuscular control stuff. If I see someone at the high school and they're not 90% limb symmetry, I got to get them through this program. We know these programs work. These are the 4 that are out there right now with the best validated research. Australia has a program, Santa Monica, the FIFA 11 Plus, anything through those. I'll make sure that we're gonna go back through this, no matter where they're at in the stage. So now at the same time they're doing this, because time dependent, if they're past 6 months, I'll start my field rehab at the same time. So again, reminder, my pieces of the picture. So now we're coming up to performance training, sport specific drills. This is the fun part. This is where we're taking the kids out. We're still doing some plyos. They're on their maintenance plyo program 2 times a week. We're starting to get our agility drills. We're doing ladders, speed drills, cutting, change direction, sport-specific drills, depending on what they are. If they're volleyballers, then we're starting to slide, work on the net, starting to loop around, work on our outside hitting. If they're football, then we're working it out of pads, but a lot of perturbations. So field rehab, this is the fun part, like I said, and so we'll take them through that. At the end, I'll do a certain test. There's a lot out there, and I'll show you in a second. I'll use the lower extremity functional test by George Davies. He's got some norms at the top. Lately, this group's been trying to do more and more norms, so it's kind of nice. So anywhere from 100 seconds for the males, anywhere from 117 to 135. Take a 10 feet wide spot by 30, and there's a lot going on, but it's a lot easier to visualize, and you'll see that in a sec. So you go through your routine, and it's nonstop, and you're just yelling at them the instructions. And again, you just get to see them flow. You get to see them move. You just get to watch. So I got Ross, my aide, to participate, ex-basketball player. He's like, I know I can do it under the time, so he's just going to work through. And then while this is going on, it almost went over to come. Also, there's, like I said, there's a lot of other ones out there. There's a good book I got a reference out there for you for other testing that you want to do for agility. They just had the scouting combine. A lot of people use any of that. And if anybody, video-wise, not too bad, huh, Mike? My 5S? Yeah. So again, if he's on the ACL rehab, I'm just looking, limbs, again, right versus left, seeing how much they could do. Little figure 8.
Apparently you didn't give him any breaks.
No, there's no break through the whole thing. Nope, it's straight through. It's, you know, head on the baseball bat, spin around and keep it going, you know. And that's the timing, the norm. So here's a group out of George Fox is doing a lot of pre-testing with it with their Division III athletes. Gosh. Yep, 90 cuts, then you cut on the inside foot versus the outside foot, and then you finish with your straight down and back, and then your backwards down and back. And I promised him I would run it the whole time because he was embarrassed about that.
What was his time?
His time was 2:05, 2 minutes 5 seconds. So, other tests. This was Dr. Riemann is out of Duke. Mansky, I believe, is out of Wichita. They put together a book, Functional Testing in Human Performance. This is their other testing that's out there. There's a lot of them. Some I recognize, some I do not. But obviously, you can use different forms of it to test them in that late phase. Not all those too. So, return to practice. We talk about medical clearance issues, coaching issues, parent issues. Them coming to you with a clearance note. How do you deal with those? I think education, telling them what to do, or how long it takes for rehab. A lot of them don't understand that. When they get cleared through to get cleared, my biggest conversation with the parents is they're not cleared for games, they're cleared for practice. And we need 4 to 6 weeks of going through practice before we see any kind of game competition. And that's if they made it through my other pieces to the puzzle. So we'll progress pretty simple, 50, 75, 100% non-contact, then go through contact, and then work their way up. The time frame kind of depends because some kids they're in the club and they only practice twice a week. Some of the high schools they're out there 5 days a week, so you get a little different advantage. So it kind of depends which scenario they're in. Then we'll go to the return to play. You got to remember, return to play, we're sending them back to the sport. They're cleared. They're 100%. They should look like they're 100%. They should be ready to go. Some will do some time restrictions. If you have a coach, whatnot, reduce their minutes. How long do they play? And if so, what sports? You know, that kind of variation. The timing of the season's important. Are you getting them in there early? Maybe they don't need to start. Maybe you can delay it longer and longer and longer and longer, because the longer we can delay them, then we know the better result that they're going to have, more than likely. And then, like I said, I have conversation with the parents all the time, with the kids, talking about the timing of, I always want to know when's the earliest they think they can return. I count backwards. I let them know if they have enough time or not. So I always educate the parents on the current timelines, what's needed to get there. Field rehab, need it. That's the biggest gap. Sometimes we don't see our ACL rehabs just based off of insurance, compliance, everything else, and sometimes they're gone by 4 months. And then there they are at the school, ready to go. And they're going to the coaching practices and things like that. So that field rehab part, I feel like is the most important part. It's also the funnest part is being an athletic trainer is getting them out there for that. And then make sure that you guys have an objective process for evaluating. Someone's gonna walk in that you don't know, or someone you haven't seen in a while and now you know why, because of injury. Your transfer patients, transfer athletes, sorry, and you want to have an idea of what you would put them through. Make sure it's objective so that you okay that one young, my niece who goes to your school, who's going to be a junior, looking that way. I want to make sure you know how you evaluate them and get them ready. Thanks.